I put up the slide for the monoamine neurotransmitters again because that's what we're going to be talking about here. Remember, we've got the catecholamines and the indolamines are two huge categories. In terms of healthcare and in terms of behavioral consequences, catecholamines and indolamines are huge, and histamine as well, not so much for behaviorally, although, yeah, that as well, but especially in healthcare terms. We talk about these a lot in Bio 202, and some of the most popular drugs, both prescription drugs and recreational drugs, involve the monoamines. So spend some time here, get really solid with these. This is a big deal. Let's start taking a look at some of the individual ones then. All the monoamine neurotransmitters are inactivated by monoamine oxidase. So remember, with acetylcholine, we saw acetylcholinesterase. For the amino acid neurotransmitters, for glutamate, aspartate, for glycine, and GABA, those were all reuptake, all right? In many cases, glial cell reuptake. Now we're looking again at enzymes that inactivate, just like with acetylcholinesterase and acetylcholine. So all the monoamines are inactivated by monoamine oxidase. That means all of the epinephrine, norepinephrine, dopamine, serotonin, melatonin, and histamine are all inactivated by MAO, all right? And in fact, MAO inhibitors, MAOIs, are used in the treatment of depression and Parkinson's disease. Like I say, in terms of behavior and health care, these are huge, okay? So think about it for a moment. An MAOI, what is that? Can you think, is that an agonist or an antagonist? Can you do that? So if monoamine oxidase is the neurotransmitter, or is the enzyme that breaks down all the monoamine neurotransmitters, and if we inhibit MAO, the monoamine oxidase enzyme that breaks down those transmitters, that means MAOIs are going to cause more monoamines to stay available in the synapse. Therefore, an MAOI, a monoamine oxidase inhibitor, is an agonist drug. It increases monoamines. As we'll see later when we look at Parkinson's, Parkinson's has to do with a deficit of dopamine. So an MAOI increases dopamine levels. It makes sense that it would do that. Drugs, the MAOIs include things like phenylzine, selegiline, and isocarboxazid, and those are still in use today. All right, those are drugs that are you'll see prescribed to this day. They're old drugs, but still around. Catecholamine neurotransmitters are also inactivated by a catechol-O-methyltransferase, which we're just going to abbreviate COMT. So keep track here of which ones are going to work on what. So like norepinephrine. Is norepinephrine, is that going to be influenced by an MAOI? Is that going to be, well, let's just do the enzymes themselves. Is norepinephrine going to be affected by monoamine oxidase? Yes, it is. Is norepinephrine going to be affected by COMT? Yes, it is. What about serotonin? Is serotonin being affected by MAO? Yes, it is. What about COMT? No, serotonin won't be affected. Neither will histamine, neither will melatonin. So the catecholamines have two enzymes that work on them, all right, whereas melatonin, serotonin, the indolamines, and also histamine have only one enzyme that works on them. So notice in the upper right, you've got something there, MAO inhibitors. This is from a nursing textbook. No popular meds, Nardil, Parnate, Marplan, all right. So when somebody takes MAOIs, they can't take any barbiturates, no tricyclic antidepressants, no antihistamines, no CNS depressants, and so on, because you get powerful interactions. And in fact, the MAO inhibitors, the MAOIs, are associated with something called the aged wine and cheese syndrome, because some of the pickled foods, you can see there in the lower right of that little cartoon, wines and cheeses and pickled foods have compounds in them that are increased by MAOIs, and they can produce things, as they say there, heart effects as well as sweating, tremors, dizziness. You really need to be careful when you start using drugs that work on the nervous system, all right, because they can interact with a lot of stuff. They make a big deal of this, spend a lot of time in nursing school about learning these drug interactions, because you can cause some serious trouble in a patient if you give them two different drugs that clobber each other. So notice then in the bottom of the diagram, side effects of MAOIs, muscle twitching, stomach upset, drowsiness, so on. All these drugs, because they work on the nervous system, they have very powerful side effects, and you have to be very careful with them. So, are MAOIs agonists or antagonists? We just answered that. Can you remember? MAOIs, those are MAO inhibitors. Therefore, they inhibit monoamine oxidase. Therefore, they make all of the monoamines more available in the synapse. They stay there longer. Therefore, MAOIs are agonists. Okay? Let's keep testing our knowledge. Glycine is glycine inhibitory or excitatory? And is it inactivated primarily by reuptake or enzymes? This is something I want you to know for the main neurotransmitters, whether they're inhibitory or excitatory, and how they are inactivated. So glycine was inhibitory. Remember, glycine and GABA are inhibitory, glutamate and aspartate are excitatory, and all those amino acids were mostly influenced by reuptake. Okay, norepinephrine, a huge neurotransmitter in terms of its behavioral effects, its effects on the cardiovascular system, and its overall effects on human physiology. So norepinephrine, also known as noradrenaline, it's abbreviated as NE. Noradrenaline would be abbreviated NA. Let's try to make something clear that a lot of people are confused about. So notice how norepinephrine sounds very similar to epinephrine, and noradrenaline sounds very similar to adrenaline. That's because they are very similar. So norepinephrine is exactly the same as noradrenaline. Epinephrine is exactly the same as adrenaline. And all four are very similar to one another. Look at the word adrenaline. So ad, Latin, means at. Renal means kidney. So adrenaline means it's the drug or the neurotransmitter that's released at the kidney. And in fact, it's on your kidney, on top of your kidney, you have a special gland. What am I talking about? The adrenal glands, all right? And they release noradrenaline. Now look at the word epinephrine. Epi means on top of, nephro, Latin, means kidney, so epinephrine means at the kidney. So once again, you've got norepinephrine and noradrenaline and epinephrine and adrenaline all being released by the adrenal gland on the kidney. That's why they all have similar names, and that's why they all have very similar effects. You can kind of put all four of those together in your head. There are little differences between norepinephrine and epinephrine, between noradrenaline and adrenaline, but all four basically have the same effects. What it comes down to really is that norepinephrine and noradrenaline have more effects as neurotransmitters. Adrenaline and epinephrine have more of their effects as neurohormones. They function more in the blood. So it's an important neurotransmitter in the brain and in the autonomic nervous system. It is one of the two major neurotransmitters of the autonomic nervous system, which we're saving for the fourth section of the class because it's such a big deal. Norepinephrine and epinephrine both raise heart rate, blood pressure, and they dilate the bronchi. So in fact, they are the neurotransmitter of the sympathetic nervous system. When a crisis kicks in, when the chupacabra comes through the door, your sympathetic nervous system will kick in, and you will start releasing norepinephrine in the brain, and your adrenal glands will start dumping norepinephrine and the other catecholamines into your bloodstream. They will quickly travel throughout your body and have huge effects on everything all throughout your body. Again, we're going to talk about that in detail during the fourth section of the class. But for right now, just keep in mind they have a big effect on breathing, on heart rate. They have a big effect on your liver and so on. There are 5 different principal norepinephrine receptors, and they name them for the first letters of the Greek alphabet. Greek alphabet, alpha, beta, gamma, delta, epsilon, zeta, eta, theta, iota, and so on. So alpha 1, alpha 2, beta 1, beta 2, beta 3. Those are the 5 main receptors for norepinephrine. Remember, acetylcholine had the muscarinic and the nicotinic. We just saw how glutamate had the NMDA and the AMPA receptors. Well, for norepinephrine and epinephrine, There are 5 major receptor types, okay? We're not going to have to know them much for the 3rd exam, but for the 4th exam, you're going to have to know those. You're going to have to know how they're different from one another. They're huge in healthcare because there are drugs that affect one but not the others, all right? Again, we can do all this from amino acids. So many of your neurotransmitters are made from amino acids. So your body never runs out. You know, as long as you're eating food, you will have plenty of neurotransmitters. They're inactivated by reuptake as well as those 2 enzymes. So again, look at how complex they are. Lots of receptor subtypes, lots of effects on lots of organs in your body, and lots of ways to reuptake them, which means there are lots of things for drugs to target. You can have drugs that target the reuptake, drugs that target MAO, drugs that target COMT. And in fact, there are just dozens and dozens and dozens of drugs that work on norepinephrine. Now, drugs that function as agonists of norepinephrine are generally known as stimulant drugs. Again, think sympathetic nervous system. These are the drugs that prepare you to fight the chupacabra. So, cocaine and methamphetamine stimulate the release of norepinephrine and they block its reuptake. Look at that. It's a double whammy. They cause you to release more and they cause you to keep more in the synapse. That's why people who take cocaine and methamphetamine have a massive sympathetic nervous system effect. I mean, they are just wired to like kill the chupacabra and eat it when they're done. So they have rapid heart rate, high blood pressure, dilated pupils, their bronchi open up. Cocaine and methamphetamine are basically drugs that are preparing you to kill the chupacabra. So they are very powerful behavioral drugs, stimulant drugs, that's what we call them. So amphetamines, Adderall, methylphenidate, Ritalin that they use for the ADHD kids, those are all powerful stimulant drugs. Adderall, very popular among college students who, you know, you put that paper off for a month and suddenly it's due the next morning. Yeah, people take Adderall, stay up all night, stimulates the sympathetic nervous system. You will be wired for a while. The problem is it also affects your judgment. You know, a lot of college students have done that. I did that when I was in college. Back then we didn't have Adderall. We had Benzedrine. It was the same thing. It was amphetamine. And I remember, you know, again, procrastinating, putting off the damn paper, saving it till the end, taking some Benzedrine, some bennies we called them, staying up all night. And the thing is, they affect your psychological side as well. So they give you euphoria. They make you feel high. And so as I was typing a paper, I would be thinking, oh my God, this is the most brilliant paper I've ever written. Oh my God, this is like Nobel Prize stuff. And I would hand it in, I'd get it back, I'd get like a C+, and I'd think, what the hell? And then I'd read it and I'd go, oh my God, this is pure crap. So unfortunately, they help you stay awake all night, but they cloud your judgment, and you don't have a good sense of whether what you're doing is very good or not. And that happens to people on cocaine and methamphetamine. They don't have a good sense of what they're doing. They don't have good judgment. So pseudoephedrine, which is sold as Sudafed, and phenylpropanolamine, PPA, are norepinephrine agonists that do not cross the blood-brain barrier. They're used in over-the-counter cold and flu medications. So what happens here is that all of these norepinephrine agonists, these stimulant drugs, another thing that they do is they reduce secretions in the oral nasal cavity. So they dry up saliva, they dry up the production of mucus and stuff in your nose. So therefore they're very helpful for colds because they dry everything up. In fact, cocaine and meth would be great cold medications. It's just the damn side effects is kind of what makes them not a good choice for having a cold. But of course, as you may well know, used to be you could buy Sudafed just on the shelves in the grocery store, and now you've got to go back to the pharmacist and like give them your blood type and promise your firstborn child, and that's because at one point cocaine was a very popular recreational drug. It's being brought in mostly from South America, and the U.S. took great pains to block the import of cocaine, and it worked. And so what happened was people had to figure out an alternative, and they did. They figured out that you could take Sudafed, and using some relatively simple household chemicals, you could turn Sudafed and phenylpropanolamine into methamphetamine. You ever see Breaking Bad, the story? That's what was going on there. You can turn simple over-the-counter drugs into methamphetamine. That's why now it's so hard to get them. And again, norepinephrine, in terms of behavioral consequences, this is the drug, this is the neurotransmitter that's worked on by drugs like MDMA, methylene dioxymethamphetamine. See, MDMA ecstasy is a form of methamphetamine. Did you realize that? Maybe you did. But yeah, Molly, ecstasy, E, you're taking a form of methamphetamine. That's why you stay up all night and dance and you rave all night long. And you feel beautiful, you feel sexy. See, it clouds your judgment. So keep in mind, stimulants, holy smoke. Norepinephrine, the neurotransmitter of stimulant drugs. Amphetamine, cocaine, methamphetamine, Molly, ecstasy. These are powerful, powerful stimulant drugs. Used to be used as diet pills as well because they suppress the appetite. Okay, so continuing a little bit here with norepinephrine, because it is so huge, and we spend a lot of time in Bio 202 talking about this. Drugs that function as antagonists of norepinephrine, specifically at beta-1 receptors, are called beta blockers. I'll bet you've heard that term before, beta blockers. So norepinephrine is the neurotransmitter that raises heart rate. Remember, we talked about that on a previous slide. Well, so if you block norepinephrine, specifically, it's the beta-1 receptors that are found in the heart. That's why the different receptors are such a big deal. Beta-1s are found in the heart, beta-2s are found in the lungs, for the most part. So if you can get a drug that specifically blocks beta-1s, then you can slow down heart rate and slow down what's called the contractility of the heart, and that will lower blood pressure. So beta-1 antagonists, beta blockers, are incredibly common prescription drugs for people with high blood pressure. They're called antihypertensives. Hypertension means high blood pressure. These drugs are antihypertensives. So atenolol, metoprolol, propranolol. In nursing school, they'll teach you the olols. All those drugs that end in OLOL are beta blockers, okay? So, again, huge impact for upcoming professional schools, dental hygiene. You guys, your injections, you inject norepinephrine directly, all right? Some of those times when you're doing dental anesthesia, a lot of those are combined with norepinephrine. You can produce very powerful effects in people. Somebody has a heart condition, you can potentially kill them with dental anesthesia. So you can see why all this neurotransmitter stuff is a big deal for the dental hygienist. Radiology techs as well, because you guys, some of your contrast media can also have effects on these neurotransmitters. Let's move on to dopamine. That's another of the catecholamines. So dopamine, abbreviated DA, synthesized from phenylalanine from the diet. It's a precursor to norepinephrine. So in other words, your body can take phenylalanine, turn it into dopamine, then turn dopamine into norepinephrine. We've seen this before. You could turn glutamate into GABA. Your body's very resourceful, very efficient, turns one chemical into another. Now, dopaminergic pathways. Dopaminergic, erg, root word means work. But dopaminergic pathways mean pathways in the brain that use dopamine as their neurotransmitter. And specifically, there's this pathway called the medial forebrain bundle, the MFB, and it's associated with what they call reward-motivated behavior. So a lot of things that, give you pleasure, food, sex, things like that, they stimulate that pathway. As it turns out, dopamine is the neurotransmitter in that pathway. So if you take a drug that enhances dopamine, it stimulates that reward pathway. And so what happens is you feel great. So dopamine agonists are drugs that produce what's sometimes called euphoria. Euphoria basically means feeling good even when you don't have legitimate reasons to feel good. As a result, drugs that work on dopamine can be powerfully addictive. And drugs, not just dopamine stimulates the MFB, but lots of other drugs also stimulate the MFB. Alcohol, heroin. So they all indirectly have effects on dopamine. So dopamine is sort of most directly sort of the pleasure neurotransmitter. I hate to say that because it oversimplifies it, but so euphoria really is the best way. So once again, cocaine, methamphetamine, and ecstasy are dopamine agonists. Remember we just saw they were norepinephrine agonists? Yeah, they're dopamine agonists as well. So what you get when people use these drugs, you get people who are all hyped up. You get people who are in sympathetic nervous system overdrive, full of energy, and they feel beautiful and loving. It's like, oh my God, keep 10 feet away from me, okay? I don't need that. So increased dopamine levels can be associated with alcohol and nicotine addiction as well. So in other words, alcohol and nicotine from cigarettes, they don't affect dopamine directly, but they can affect that median forebrain bundle, and so that increases then the dopaminergic pathways in the brain. Dopamine itself, therefore, is associated with all kinds of addiction, including heroin, alcohol, nicotine. Now, in certain parts of the brain, in the basal ganglia, or basal nuclei, they're now called, for reasons that are not understood, there are dopamine neurons that die. And that's what produces Parkinson's disease. So what do you suppose you would do if somebody had Parkinson's? Well, somebody with Parkinson's, it means that neurons that produce dopamine have died. Therefore, dopamine levels in the brain are lower than they should be. So what do? Well, a lot of Parkinson's drugs are simply agonists of dopamine. They increase dopamine levels in the brain, all right? So we'll talk more about that coming up, and when we do the brain, we'll talk more about that as well. Continuing with dopamine, schizophrenia is also associated with increased levels of dopamine in certain regions of the brain. This is known as the dopamine hypothesis of schizophrenia. Now, there's some evidence for it and some evidence against it. So it's not totally agreed upon, it's not totally clear, but it does seem clear, at least to some extent, schizophrenia and dopamine are connected, at least to some degree. And that's why many antagonists of dopamine are drugs that we call antipsychotics, used to treat schizophrenia and other psychoses. So chlorpromazine, soldestaurazine, haloperidol, Haldol, trifluoroperazine, stelazine, those drugs are all prescribed for people with psychosis, people who have schizophrenia, people who are sort of disconnected from reality. It's a brain condition, it's a real thing. Now think about it. The deal here is that with Parkinson's disease, there were certain parts of the brain that lose dopamine neurons. What you would really love to do is increase dopamine just in those parts of the brain. Unfortunately, if you give people dopamine agonists, it doesn't increase dopamine just where you want it to. It increases dopamine everywhere. Likewise, so for the Parkinson's people, then if you want to give them, the schizophrenia people rather, you want to give them dopamine antagonists, because the schizophrenics and the psychotics, they have too much dopamine in certain parts of the brain. You would like to have a drug that only decreases it in those parts, but it doesn't work that way. Unfortunately, the drugs that are antagonists of dopamine can affect other parts of the brain as well. So guess what happens here? You have Parkinson's patients, and they're taking dopamine agonists, right, to make up for their loss of dopamine neurons in certain parts of the brain, but that excess dopamine may influence the parts of the brain that are associated with schizophrenia. And so when Parkinson's patients who take these drugs long term, they may begin to have some schizophrenic type symptoms. And likewise, the poor schizophrenics, as if their life wasn't difficult enough already, they start taking these antipsychotic drugs to lower the dopamine levels, and that may help with their schizophrenia, but it also gives them Parkinson's-like symptoms as well. So can you see how complicated it is when you're trying to give drugs to people? Drugs don't just work in the one place you want them to. They work everywhere. That's why the pharmaceutical companies are always trying to make better and better drugs. They're trying to find more and more different kinds of receptor subtypes, and therefore, the brain researchers keep finding more and more kinds of receptor subtypes, and then the pharmacy people keep finding drugs that will work on only that receptor subtype. That's trying to make drugs more and more and more specific, all right? So But this is why. Drugs may affect all the parts of the brain, and therefore you get not only the effects you want, but you get some very unpleasant side effects as well. Let's move on then to continue with the monoamines. We're now done with the catecholamines. Catecholamines were norepinephrine. We didn't really talk directly about epinephrine. You can think of epinephrine and norepinephrine as having basically the same effects. And we talked about dopamine. Let's now move into the indolamines. Serotonin 5-HT is the main one we're going to talk about. We're not really going to talk about melatonin. I talked about that in Bio 202, but not really very much in Bio 201. So serotonin, again, its more technical name, 5-HT, 5-hydroxytryptamine. It's made from the amino acid tryptophan. 90% of your body's 5-HT, by the way, is found in your GI tract. Has a lot to do with digestion. All right, only a small amount is found in your brain. It's also, by the way, a vasoconstrictor, so it has important properties in the cardiovascular system regarding blood clotting. Only something like 2% of your body's serotonin is found in your brain. So don't be misled by all the garbage you see out there on the internet about serotonin. Remember, only a little bit of it is in your brain. It mostly has effects on other things like blood pressure and digestion. So agonists of serotonin, which block reuptake, are often prescribed as antidepressants. These are there are the old-fashioned ones, the tricyclic antidepressants, the TCAs. They block reuptake of both serotonin and norepinephrine. They include imipramine, tofranil, amitriptyline, Elavil, and clomipramine, anafranil. By the way, imipramine, tofranil, is still known as the gold standard of antidepressants. As far as antidepressant meds go, these old drugs are still really good. The problem is that they had big side effects, all right? Again, it's like I was talking about just a moment ago. They don't work just where you want them to, they work other places as well. So some of these old antidepressants were actually really good. They're as good as modern antidepressants when it comes to actual depressant effects. But the problem is they had lots of side effects. So what's happened now is agonists that block reuptake, prescribed as antidepressants, there's a whole new class. They're called SSRIs, selective serotonin reuptake inhibitors. So whereas the tricyclics were working a lot on both norepinephrine and serotonin, the SSRIs are working mostly on serotonin. They're prescribed for a lot of things, by the way, besides depression, eating disorders and panic attack as well. SSRIs include drugs I'll bet you've heard of: fluoxetine, Prozac, citalopram, Celexa, paroxetine, Paxil, sertraline, Zoloft. These are some of the most prescribed medications on planet Earth. As a matter of fact, these days, if you go to the doctor, doctors, once you've been in their office for 5 minutes, they're already getting impatient. They're trying to move you down the assembly line so they get more people in there. So if you ever say to your doctor, I feel depressed, I don't feel like I used to, I'm not as excited about things anymore, I'm feeling kind of down, I've lost interest in life, they'll just basically grab a script pad and write you a prescription for the SSRIs, all right? Very common. By the way, double-blind studies have shown questionable effects of these SSRIs. The effects may be really more placebo effects, which doesn't mean they're false. It just means that it's not really the drug itself. SNRIs, DRIs, SNDRIs are newer reuptake inhibitors. Can you figure what those are? SNRIs, serotonin norepinephrine reuptake inhibitors. DRIs, dopamine reuptake inhibitors. SNDRIs, that inhibits everything: serotonin, norepinephrine, dopamine. Many psychedelic drugs are direct agonists of 5-HT, so they don't block reuptake, they actually bind to the receptor itself. So drugs like LSD, psilocybin, the stuff that's in the magic mushrooms, DMT, mescaline that comes from the peyote cactus, these are drugs that directly activate serotonin receptors, and only certain subtypes as well. There are a lot of different kinds of serotonin receptors. These don't activate all of them, just some of them. But hopefully you can see that serotonin, very powerful neurotransmitter, very powerful behavioral. Think of if you've ever seen somebody on the under the influence of psychedelic drugs. Holy smoke. So serotonin, a very important neurotransmitter, has very powerful behavioral effects. All right? Now, I'm going to warn you about all the garbage that's out there about neurotransmitters. I see it on the internet every day. It's really just embarrassing. You see diagrams like this. So schizophrenia, oh, it means you've got too much dopamine. Anxiety, oh, you don't have enough dopamine. Happiness, oh, you've got lots of serotonin. Depression means you're low on serotonin and on dopamine. Love means, ooh, look, you've got lots of whatever, oxytocin, serotonin, and dopamine. And there's fight or flight. This is just colorful nonsense. This is just garbage. Hopefully you've seen so far that the neurotransmitters are so complex in their behavioral effects. There are so many different kinds of receptor subtypes and so on. You find these neurotransmitters working in so many different parts of the brain, so many different parts of the body, that the idea that any one neurotransmitter can be pinned down to one effect is just silly. It's just nonsense. So due to different types of receptors, specific locations of the receptors, different parts of the brain and nervous system, the effects and interactions, the cofactors and co-transmitters, this diagram is just garbage. It's just ridiculous nonsense, okay? So for example, there are currently over 15 known types of serotonin receptors found in various locations throughout the brain and the body. They control things like addiction, aggression, gastric motility, anxiety, appetite, blood pressure, heart rate, vomiting, memory, mood, nausea, pain, penile erection, learning, memory, pupil dilation, respiration, sexual behavior, sleep, thermoregulation, and vasoconstriction. So I see people on the internet saying, I want to know how I can increase my serotonin. And I normally answer and I say, why? Are you constipated? 90% of your serotonin is found in your GI tract. Well, no, dude, it's like serotonin's like the happiness neurotransmitter. And I say, okay, look, don't ever talk to me again, all right? Don't ever talk to me again as long as you live. Prozac. Sometimes you feel like a nut, sometimes you don't. I took my Prozac today. Force that smile. Prozac, mood brightener. Better than ever. Freshens, cleans. Wash your blues away. Yeah, this is all crap. Kellogg's Prozac pills. They're great. Yeah. They have a special offer, a Courtney Love action figure. You guys don't know who Courtney Love is. That is just so perfect. She was Kurt Cobain's girlfriend. Really, you know what a lot of people need who are taking drugs? Really, this is what they need. A drug called No One Cares, the pill for chronic complainers. Recommended to be taken with a nice warm cup of shut the hell up. If not 100% satisfied, too bad. All right. Look, top right. Hypochondriac, pay too much tax, boss not fair, not getting any, back hurts. No One Cares is for you. Look, the real thing, and what doctors should be doing, if someone is depressed, you don't cure depression with a pill. The pill may help depression. You cure depression by sending them to a counselor who sits down and talks with them and finds out what the source of their depression is and basically helps them come up with real-life behavioral strategies, cognitive strategies for dealing with the depression. You can't cure things with a pill. It's much more complicated than that. Keep that in mind.